Thank you very much. I think, before I start, I'd like to mention one thing. I think long back in BB, people had called me over to do a live surgery, and I don't remember how many years back it was. And when I just entered the hall, I saw on the big screen somebody operating, and I was dumbstruck. That surgeon was so good. I mean, I called them and I said, wow, who's this surgeon? And then they told me, this guy is Ajay Paul. I have yet to see someone operating like Ajay Paul, to be honest to you. I mean, his skill is in that level. And I'm being very honest to you, Ajay. I'm not just telling this because you are sitting on the dais or it is your course. This is the honest truth. I've seen very few surgeons in the skill which Ajay Paul brings. And for me, it's a pleasure to come here and speak. Actually, it was Susan Jacob to speak, but since she is operating in Chennai, so they asked me to come and speak. So let's see this. This innovation of Susan, to be honest, she's brilliant, is hers, it's not mine. So I cannot take any credit for it. We call it as the Jacob glued capsular hook. So let's watch it basically here. And last year, this won the American Academy, not last year, the last two before that, the global contest also. So let's see what this system is. Now you have various types of subluxations, They showed 270 degrees or more, in which perhaps endocapsular rings are an answer, but they will not work once the subluxation is this much. So in such cases, you go ahead obviously with the Sioni ring, which was shown very nicely, and again Bob Sioni changed the whole game in subluxation, or the Amar segment, which Ike did. But look at this case. This is a case which came to us post-operatively after someone had done an Ike's MS segment. But look here, the suture is broken. And because of that, the whole lens got subluxated. So when you fix cases with sutures, and today perhaps they use Gore-Tex to prevent the suture breaking, there are problems of this subluxated capsular bag complex subluxating down or getting post-operatively subluxations. To solve this problem, the glued capsular hook was started. So let's see what this is about. Basically here you're making a scleral flap exactly in the area where the massive subluxation is. And this is a simple capsular hook. You can see it goes through the sclerotomy, goes inside and hooks on to the rhexis. Once you have hooked on to the rhexis, you just have to pull. Once you pull, now watch, I can cut the remaining portion as much of haptic of that capsular hook which you have. Now create the chariot's tunnel just like you would do in the glued IOL. Once you have done that, all you need to is flex this glued capsular hook, the haptic portion of that, into the tunnel, seal everything down with the fibrin glue. The advantage here is there is no suture, so the breaking does not happen. Second thing, it's quick and easy compared to the other types of rings, etc., which you are using. Now let's take a particular case here, and I'll show you the case here. You can see here, if a patient has got massive subluxation, the key is to create your flap in the area where the massive subluxation is maximum there. Now once you have made the flap, you go ahead and do your rhexis. Now watch, with the sclerotomy going there, it's just going behind the iris. Once you have done that, this is the capsular hook which you all use. All you're doing is bending it a bit. Once you have bent it, and I'll be talking more on this in the National Symposium also, but you can see it goes inside there, behind the iris, and that hook locks on to the rhexis margin. If there is some vitreous there, you can also remove the vitreous. In this clip, there is not there. Either way, the principle is very simple. You are latching on to the rhexis margin. Once that bag is latched on, you can see there, the bag gets stable. Now that's the radial stabilization. You want to have a circumferential stabilization also. So in this case, all you do is your normal endocapsular rings now can be fixed. Because now you see the bag is stable. So now you can fix a endocapsular ring just like you would normally do. Now remember, when you do phaco, you want the bag to be more stable than what it is right now. Though you have a radial glued capsular hook and a circumferential endocapsular ring. So all you need to do is, where the subluxation is, these are temporary translimbal capsular hooks. So you can see one fixed and you can see the second fixed. So once these two are fixed, but remember, these two will be removed at the end of the surgery. They are not going to be there permanent. Now you have a very solid, stable bag. Now you can fix the bag with iris hooks, and I see many doing that. The problem here is, if you use an iris hook, it's got a sharp edge. You can tear the rhexis, and once the rhexis goes, the game is over. So now your next step is, you do the nucleus phacoemulsification. See how stable the bag is when you're doing it, because you've got already a centrifugal and a centripetal force working. Now, once that's done, do an irrigation aspiration. Now, at this stage, ladies and gentlemen, you can put any lens of your choice. Okay? My personal advice is to always put, to be honest, in such cases, a 3-piece IOL. Because suppose some complication happens even at this stage, I can easily convert to a glued IOL. But again, if you have a nice bag, I'm not saying no, you can put a 1-piece foldable IOL in the bag also. But in our system, we prefer to put a 3-piece IOL by and large, because if there is a complication, it gets very easy to convert the game. Here you see we have put a 3-piece IOL. Now, once you have done that, remember the tunnel I was talking about? I'm going to create that Gabor-Charier's tunnel. Again, same game like we did in the glued IOL, which Dr. Narang explained beautifully about. Here, once the tunnel is created, all we do is pull off this plug. I don't need that plug anymore. Now, assess how much of haptic is there of the glued capsular hook. If it's too much, that excess portion I don't need. All we need to do is cut it. So here you can see we are just cutting it. Now flex it. Once it is flexed, you can see now we are going to tuck it into the tunnel. Now the big advantage in this here is, we can tuck as much, untuck as much. In other words, if you do suturing, once you have sutured, you're going to get stuck in it. Here you can tuck, untuck, move it this way, that way, till you have the bag well centered. Now remember the translimbal hooks, all we do is remove them. Here you can see both of them being removed. Once that's done, check IOL centration. If it's not centered, very simple, I told you, you can tuck more or untuck more. Either way, the game is on now. All you do is apply the fibrin glue. This is from T-Cell Reliance. Many people have this. It is fibrinogen thrombin combination. Seal everything down and complete the case. So ladies and gentlemen, this is the same patient, 7 weeks post-op, you can see, with a very nice stable bag completing this particular case. So I think now we are running short of time, so I'll close up now. But my main idea was to show you on this particular technique of the glued capsular hook for subluxated cataracts. Ajay.
Thank you, Amar. And I think there was a really great innovation where you can use that capsular hook as a glue. Can we, use, I think there was one more invention where you have a bigger, the bigger area of, instead of holding the capsular margin, you can have the...
So I'm going to show that in the national symposium, that is the next session exactly. So I didn't want to show that exactly here. What we have done in that is to give a broader base. See, understand, the glued capsular hook gives you this much of a base. It's better than an iris hook. So to solve this problem, Susan invented another system which is made of PMMA, and since Ajay is just asking, I didn't want to show it, but I'll just show it to you in a second for a minute here. Is that on? Can you give me my plug on? Just, can you get the screen on?
Yeah.
Okay. If you see there, just watch that in a second, but listen, that's what I'm going to show you, and that's what he's talking about is, you see the base becomes slightly broader. So once it becomes broader, you get a longer area to capture onto it. And you can see that's how the system works very simply. This is made of PMMA, and I think this gives you a broader perspective. See, Iris hook gives a little perspective, Capsular hook is more, but this glued Capsular hook, which is the latest device which Susan brought out, which is called the paper clip, because it's actually like a paper clip, will be much better off.